Well, good evening, everyone. Welcome to the Healthy Living and Siani Group collaboration. We are so excited to be here today. I am Chanel Brandon. I'm the Secretary of Healthy Living with a Vision Foundation, and I'm glad to be with you guys on this wonderful Friday evening. You could have been doing a whole lot of other things, but being here is where you needed to be. So we thank you. We thank you. Lucky, we want to thank you for having this affiliation. Dr. Johnson, Dr. West, Dr. Wheeler, and Dr. Thompson, thank you all for being on the call, and all of our participants. We are gracious and grateful that you are here with us today. I'm going to turn this over to Dr. Johnson, who is the CEO and founder of Healthy Living with a Vision, and he'll give you more information about our wonderful foundation. And then Lucky will get an opportunity to also collaborate about the Siani Group.
Well, first of all, my name is Dr. Ansel Johnson. I'm an optometrist, the CEO and founder of our foundation, and we were founded on June 19th, 2020, right in the middle of the pandemic. And I just want to give you a big overview. And also, I want to thank our collaborator, Mount Sinai Hospital, because this is our first of hopefully many joint collaborations in which we can fulfill our mission in terms of getting good information and services out in the community as it relates to our healthcare. And our mission basically is to eliminate healthcare disparities in individuals through health education, economics, and removing, barriers, systemic barriers to care, and also partner with some cutting edge technology companies and research to provide robust and more robust healthcare. And so on here, and I'm going to go through this briefly, is our board of directors, a phenomenal group of people. Carl Bird, our vice president, who's administrator with City of Chicago, Chanel Brandon, who you see here, Dr. James Thompson, our medical director, and Dr. Angela Wheeler, both of whom are on our panel, Mr. Allison Debonet, who's a business person, Diane Powell, who's also on the line, former CEO of Roseland Hospital, social worker by trade. We have Sherry Withers Smith, who is a nutritionist, but she's also a Whitney Houston, I don't want to say impersonator, but she's a Whitney Houston performer, just phenomenal individual who is living with lupus. This is Lupus Awareness Month, and I'll tell you a little bit more about that later. LaShawn James, who's vice president at his home care, whose mission is to help educate people on home health, home care. We have Tony Oates, who is our own registered nurse, who's always out there in the community doing some positive things. Deborah Hurston, who really is at the very beginning, helped us form this organization in terms of governance. She's our only out-of-state board member, but insight into associations and just has been phenomenal in our formation and growth. Jamila Pointer, who is a senior vice president of Associated Bank, with also an interest in healthcare, and Reverend Joaquin Berry, who again is phenomenal individual, works with a number of non-for-profit organizations. So this is a group of people that is behind Healthy Living with a Vision, that's excited about moving our mission forward, because we have a plan for healthcare and health advocacy in Chicago. And again, some of our community partners, Addis Home Health, Home Care. And our newest corporate partner is Leo Burnett. Leo Burnett is probably one of the most well-known, most well-recognized marketing and advertising company, not only US, but worldwide. And we are their first Leo Love company, a non-for-profit that they are supporting and they are spotlighting. And as you all will see later on as the year goes on, you should be seeing most of us, Healthy Living with a Vision, in terms of that partnership, and is a Leo Love Foundation. Again, coming back to our partner for this presentation, Mount Sinai Hospital, has gotten quite a few awards over the years. in terms of a national excellence in terms of research consulting and home care, healthcare award winner, and the top 25% nationally in terms of overall quality of care in 2014. 2018, they earned an award for maternal care and the treatment of hypertension. 2018, a Distinction Center of Maternity Care from Blue Cross Blue Shield. And also in 2018, they have a Lifetime Silver STEMI Award from the American Heart Association for their cardiology department. So again, it is such a blessing and a pleasure to partner with Mount Sinai. And part of what we've done so far, and we have able to give out 430 COVID tests, because as we know, those tests are no longer free, but we were able to distribute quite a few in a very short period of time to instruct people on how to properly use them. A lot of people got free COVID tests, but we're not using them properly. So we had to put those things together. We've been instrumental in providing free diabetes education sessions for people living with diabetes or even living with pre-diabetes. We've done some town hall meetings on people that have vision impairment. And we have a national panel of experts that I was able to put together here. We have another one coming up in June. This is Lupus Awareness Month, as I mentioned earlier. And our board member here, Sherry Withers Smith, along with some experts and actually people that live in champions of lupus, we did a very good in-depth town hall meeting about lupus. We were one of the first organizations to actually do a COVID broadcast. I think this is January of 2020. We actually did it before there were vaccines, when people were wondering where should they get tested, why should they get tested. So we have done a series of COVID town hall meetings. We've actually worked with 2023, just this past winter, with Chicago Urban League with their own community health forum and health fair, where we provided vision screenings. And one of our newer initiatives, there's an epidemic with nearsightedness or myopia, and my associate doctor, director of myopia management services, we're looking to raise funds and provide treatments for children whose prescriptions get worse and worse and worse every year because of so much increased computer and cell phone use. So we want to be able to provide grants and funds for patients and families that may not be able to afford it otherwise, and also increase awareness.
You hear me? That's my door.
Yes. So we're on the forefront of that. So that's what we do with Healthy Living with a Vision Foundation. We're going to turn this over, but one thing, we are not shy about asking for donations so we can expand our services. So who's ever on the line, tell your friends. Our website is healthylivingwithavision.org, healthylivingwithavision.org, where you can make a donations. I don't care how small, but we just need your support so we can expand these type of programs, not only virtual, but in person. So with that being said, I'm going to stop sharing and turn this back over to our next speaker. And Chanel, you can introduce our next speaker. Dr. Joseph West.
It's our pleasure to have Dr. Joseph West on the call with us today. We are so grateful that you took the time out on your busy day where you will be doing service work for Malcolm X and spend some time with us today. So Dr. West, I'm going to turn it over to you and let you tell us about yourself and get ready for your presentation. Thank you for being with us again. Let me get this over to you real quick.
Thank you all for inviting me. This does count for a day of service, so so it all fits and it all fits well. So it's very blessed and fortunate there. All right, so as everyone can hear me, my name is Joseph West. I'm an epidemiologist and statistician by training. I've spent quite a few years working in a number of capacities. Particularly, I spent about 7 years at Mount Sinai Hospital, at the Sinai Urban Health Institute for a while, and then left there, and then began work and co-founded a Medicaid HMO, Next Level Health, and since then been working a lot with FQHCs across the country on a number of initiatives specifically focused on Medicaid, and also with large foundations like the Robert Wood Johnson Foundation, MacArthur, Ford, and others, focused on access, Medicaid access to care, particularly dental care, and maternal and child health, as well as mental and behavioral health services for young men. And so recently, as of last year, one of the companies I've been working with for quite some time, the last 3 years, is a company called Clinify Health. At Clinify, I'm Executive Vice President of Business Innovations and Solutions. And Clinify is actually a technology company, but we're a bit more than that. We're a startup company that is venture backed. We're supported and funded, for example, by a number of the major payers, our investors. Johnson & Johnson recently invested in us, and we're included, for example, in the Amazon incubator, as well as other tech incubators. And what we're doing is that we are focused on FQHC population and really bringing FQHCs, community health partners, connecting the dots between Medicaid managed care, members who are eligible for Medicaid and all the different types of services, and really engaging the community health centers, partners, and other providers like Dr. Johnson and others who are willing and prepared to really engage community health centers around data and around, really providing care to close care gaps for the hardest to reach and hardest to manage populations. So as some of you all may or may not know, FQHCs are considered the front line of community-based care. For over 50 years, FQHCs have been at the heart of communities providing care with providers that do everything you can imagine, from primary care to OB/GYNs to physical, having the primary care PCP, as well as social services, mental health services, substance abuse, temporary and transitional emergency housing, you name it. FQHCs do a lot in our communities. And so what we're doing is we began to look at and partner with FQHCs across Chicago and across Cook County. And we looked at, and we've been working with and using data to look at, for example, average life expectancy, right? So when you look at Chicago, where the lowest life expectancies are, they're in some of our hardest to hit neighborhoods. I mean, here you have North Lawndale, where Mount Sinai actually sits. And then you have, here on the south side, where, Inglewood, Washington Park, and all of the communities for which a number of us are familiar that really, really struggle in terms of not only health disparities, community violence, and other issues. And so we began working with a set of community health centers all across, wrong direction, Chicago. One of the pilots that we're working on, just to kind of highlight it, is that we're working with 5 community health centers that are connected. They're Beloved Community Wellness, Chicago Family Health Centers, Christian Community Health Center, Family Christian Health Center, and TCA Health. And essentially what we're working on is they're using a platform to connect members who are eligible and qualified for Medicaid to specialty care and refer them for services. For example, for an eye exam. So if you're a patient that has diabetes and one of your care gaps or care needs is to have an eye exam or a foot exam or other specialty care referral, then they're coordinating and working on this together. One of the reasons for doing so is because we know that housing instability is one of the social determinants of health. So being able to capture members who move quite a bit between neighborhoods they tend to pop up in similar community health centers. So this approach allows them to start a care plan, start engagement, try to reach out to members without having to, every time that member moves, having to start over with care. So Clinify Health, with this particular pilot, we are working with a number of health centers across, as you can see, Chicago. Here are all the clinics that we're working with in red, and the ones that are participating in our pilot are in the sites and locations are in blue. We're also participating in a couple of the state health transformation collaboratives as well, really bringing together and tying together the data from the fees from the hospitals, fees from payers, fees from nursing homes, and also from social service agencies, et cetera. And so we are focused, for example, for our pilots, for this one particular pilot that I'm highlighting here, is around diabetes and diabetes care. And one of the big, care needs or care gap needs is eye exams and diabetes education that can come from, for example, an eye doctor, that can come from a foot doctor, that can come from even being referred to what's called diabetes prevention program that is delivered by a community health center. So we're excited that, to bring together a group, a collaborative of FQHCs to really focus on addressing not only those care needs, but really looking at data to address social determinants of health, right? And so we're measuring and creating a structure around certain patient characteristics. So for example, how many needs they have, is it housing? Do they have concerns about environmental safety, food issues? Do they have behavioral health concerns around drugs, alcohol, relationships, personal relationships? We're developing an integrated family approach that not only looks, for example, at maternal and child health as just, the mom and the child, but also the family system, which includes engaging men, fathers, and others in the family environment together. So in bringing all that information together. And as we're, moving organizations through the pilots, we're, measuring processes that work best for the people that need them. So, what's the best time to schedule a foot exam? What's the best time to schedule an eye exam? How far away are, people from services? How long does it take them? Do they have to take, 2 buses, or do they have to take a bus and a train? Or, are they susceptible to receiving, transportation and transportation assistance? And we want to, really reduce the costs of their care, hospitalizations, and other needs. We create customized social determinant reports that tie back to quality of life outcomes, that tie back to data that go back to the insurance companies, but also is data that informs the processes and work of the FQHCs. So they can then take that information, SDOH reports, and they can apply for other grants, because we know that, even with their encounter rates, they don't receive enough funds for sustainability. So they're constantly having to apply for grants from HRSA, CDC, NIH, and other funders. So by using our platform, as well as some of our, know-how and technical support and resources, we can provide them with the types of information that they need to take these reports and then generate them into useful data and information that they can then turn around and receive funding from other funders. So, just quickly, as I mentioned, Clinify Health is a BEP-owned business. There are 4 African-American men that own the company, along, as I said, with other investors, but there are 4 of us that are leading the company. And we started in one of the Chicago Matter incubator and some of the other incubators related to Amazon and some of the other technology partners. And so we have kind of grown over the last 3 years, really into a technology platform that is consumer centric, that's been informed by the FQHCs, that gives them the type of tools that they need to measure their performance, It helps them manage risk, if you will, and also really helps them, reach out to members that are hard to reach. So, for example, if one of the payers, one insurance company, incentivizes patients to complete a wellness visit or a well child visit, they can easily identify who that patient is or who those patients are, and then customize an outreach strategy to them so that they can actually not only take advantage of the benefit that's a part of their insurance, but also, maybe for the first time in a long time, engage a primary care physician in their care. So we're really, excited that we're able to not only create something to get into the what's called, the tequity space, to close, gaps in technology use, gaps in technology innovation that, do not necessarily make it to community health centers or community partners because of costs and other barriers, that we're able to really break some of those barriers down and find resources and opportunities to bring that technology to bear. And then just lastly, we are, one of the things that we're working on a lot, which is relevant to community outreach, is reaching hard to reach persons. So for example, being able to reach a pregnant mom who's homeless, who's, showing up in the emergency room, right? And so, but if she's homeless and she's pregnant, someone needs to get out there, to her to be able to, get her into prenatal care and other services. And so being able to use our platform as well as other resources that come through the platform to be able to do those kinds of things of prioritizing who to reach out to, engage those members, and then retain them within a care model has been really, really important. So that's, a bit of who we are, that we're focused on data, continuously using data and bringing it to insights in ways that typically are not used in community initiatives, or typically not used or leveraged for clinical decision making for, higher risk members and for community health centers. So I'm happy to answer any questions that people have about how we're doing. We're working with, as I said, in Chicago, but we're also working with FQHCs across the country. So we're excited about what we're learning. If you work with one FQHC, you've only worked with one FQHC. If you work in one market, you've only worked with one market. So we're learning a lot from the way in which community health centers deliver care and work with partners like Dr. Johnson and his foundation and others to really be innovative in thinking about providing services to the people that tend not to have access to them.
Are you taking questions now, or are we going to do questions later?
That's up to the host. I'm happy to take questions now, but that's up to the host if we can take them now, or would they like for us to wait later?
Dr. Johnson.
Dr. Johnson, it's up to
Yeah,
you.
we can take a couple of questions now, but we want to move it forward. If we can take two, and then, if there are any additional questions, we can save them until the end.
And then we can all
and
come back to them.
should I ask my question?
Yes.
Yes.
Go ahead. And then,
Okay, I am wondering what, if anything, if you're in discussion about how you might address healthcare issues should the government default and people are no longer getting their Social Security. Is there a plan somehow to still provide them with services?
That's a bit outside of our scope at the moment. I mean, we're focused on particularly on the Medicaid population and Medicaid eligibility. So when the states receive, those Medicaid, block grants and funding, and then they get dispersed through their managed care, or they get dispersed through their state Medicaid programs. That's where we're particularly focused. So that includes, potential populations that may or may not be eligible for Social Security. So unfortunately, that right now that's not within the scope of the work that we're doing.
Okay, thank you.
Any other questions? All right. Well, thank you, Dr. West. We appreciate that. That was phenomenal. Great information, great insight. Dr. Johnson, Dr.
Yes.
will be our next guest, so I'm gonna let you introduce her.
Our next guest is again one of our founding board members, Dr. Angela Wheeler, who is a family practice physician in Indiana, Northwest Indiana. Just phenomenal, not only just physician, but a human being. And she's done a number of things, including working with the United States Olympic team. So in terms of working with our best and brightest athletes. So with that being said, I will turn this over to Dr. Wheeler, our next speaker and presenter.
Hi, good evening, everyone. I'm Dr. Angela Wheeler. My specialty in medicine is family medicine. And I did do a fellowship in sports medicine, hence my sort of door open to the work with the Olympic Committee. I did go to the Sydney Summer Games in 2000 and took care of 3 teams for the Olympics. So that was a real highlight in my career. So Dr. West, thank you so much for that presentation. And I'm gonna just kind of dovetail on some of the things that you talked about. What I wanted to really focus on today is maximizing the primary care visit. So once you have a place to go, then how do you get the most out of those visits? A couple of points I want to talk about is, why is the primary care provider important? How do you prepare for that primary care visit? And what to do to make the follow-up best for your needs going forward. So first question, why is the primary care provider important? Well, hopefully this individual will be someone who will get to know your family and your family dynamics. That would include everything from, who's really the spokesperson for the family, who has, the major responsibilities in terms of, some of those determinants of healthcare that we talked about. The primary care physician can address most of your healthcare issues, everything from just wellness in general, things like immunizations, and then seasonal things like, cold and flu and sports physicals, all kinds of things, your doctor can do. I think that with our recent, I'll call it a season for COVID, the primary care doctors were very, very instrumental in helping people figure out, how to navigate through that, not just from a medical standpoint, but just from, dealing with family dynamics when everybody's kind of stuck in a house together. Also, your primary care physician that gets to know your family would be someone who would be interested in your cultural practices. Now, this can be important, for instance, if you have someone with diabetes, and if the primary care physician takes the time to learn about some of the cultural practices, foods that are eaten, observances like Ramadan and things like that, that will build a connection between the family and the patient and help them figure out, what's the best way for me to eat? What kind of things can I eat that I usually eat? What kind of things do I need to stay away from? Your primary care physician can really help with those kind of things. One of the biggest things a primary care physician can help with is avoiding that expensive care in the emergency room. So in a lot of communities, for various reasons, people go to the emergency room for everything. I remember when I was a resident, I had the ER duty, and I was called to the ER to see a patient, and this lady had called an ambulance to come in because she needed a pregnancy test. And if that isn't, an example of misuse of the emergency room, I can't think of a better example. But anyway, that's something certainly that a primary care physician could do in the office. And then really even to make sure that people understand what it really is the purpose of the emergency room. The emergency room really is a place to deal with emergencies. And you can break that down into, is it going to take you out in the next 24 or 48 hours? If that's the case, that's what they handle. It's really not their job to make you all better. It's just to decide, is there something that is really, really emergent, something that needs to be taken care of in the hospital setting? If not, then they're going to pretty much stabilize you and send you out. And hopefully where you would be going would be to a primary care physician who can take care of things from there. So once you have made an appointment to see your primary care physician, and we realize that access to care one of the barriers to access is just having insurance. So hopefully most of our population can find some insurance one way or another. But once that happens, so how do you maximize that time with the primary care physician? More and more our time is crunched. So if you're organized and you have your questions and your issues kind of in front of you, you can get the best out of the visit. So one of the first things that you want to do is really kind of either gather or know your family history. There are some medical issues that your family history can make a difference in how we approach, how we treat, how we follow. So that could be very, very important. Secondly, knowing your allergies and what the reactions are. So a lot of people will come into the office and say, I'm allergic to penicillin. So what is the reaction? Well, I don't know. That was what my mother told me. I'm allergic to penicillin, so I don't take penicillin. So, that leaves us in a position where if you need an antibiotic, can we use something related to penicillin, or do we really need to stay away? So the reaction that an individual has to an antibiotic or some other kind of medication really makes a difference. Having that information can be very, very important. Also, if there is a known medical condition, being able to provide as much information as possible helps us. It helps a lot if we don't have to draw it out of you. And I'll just give you an example about how that happens. So sometimes, and I'm just gonna, I'm gonna call it the way I see it, is that when I have a male patient coming in for a physical exam, and he's, let's say, between the ages of maybe 18 and 35, and he says, I need a physical. My question then is, what's really on your mind? Because if we just kind of go along the lines of a general physical, we can be talking about all kinds of things and never really get to the issue that you're concerned about. So, my next line of questioning would be, really tell me why you're making this appointment. If it's not because your mother, your girlfriend, your wife made you come in, or you need a physical for a job, then there's something on your mind. And so if you can just be, come forth with that, that will help us focus on what's really needed. And I really hate the thought of a patient coming in and leaving with the same question that they came in with. So if they can, make it clear what their concern is, that helps a lot. Also, information about surgeries can be very helpful. When patients come in, we need them to know their medications. That would be nice. A lot of people really don't know their medications, don't know what they're for, don't really have an idea of what their what the potential side effects are. And they don't bring their medication bottles, so that if they can bring their medications, then that gives us an opportunity to really go over the medications with them, make sure that they understand the purpose of the medications, and also, potential side effects. I'll just tell you a story that actually happened today. I saw a gentleman, and he went to his cardiologist. I had started him on a medication for his cholesterol, and he had gone to his cardiologist because he had some chest pain. Cardiologist put him on another cholesterol medication. So for about the last month, he's been taking 2 medications for his cholesterol. And I said, oh my God, that's a disaster. That can absolutely destroy your liver. But fortunately for him, he brought the medications in, and that gave me an opportunity to, really help him understand that that he was, taking something that he shouldn't take. I mentioned something about people coming in listing their concerns, and sometimes the way people sort of handle that is they do a Google search. So some physicians are cool with the Google search and some are not. My position on that is this, that if you want to look up either symptoms or medical condition on Google, go ahead if you want, but bring that information to the office and let's talk about it. The problem with Google is there's so much information there that you don't really know what applies to you. So it can, have you thinking you're going to die at any moment, and maybe none of that stuff even applies to you. So I don't mind people doing a Google search, but certainly come in with your questions and I can help you figure out, what's important for you. One other thing is sometimes the patients will need a referral to a specialist. So depending on the type of insurance they have, they really need to check with their insurance as to what providers are in network. So particularly if they have an HMO and Medicaid, those type of insurance products, they should give some thought to checking ahead of time if they can. So if they come in and they know they have chest pain and they think I might send them to the cardiologist, it would just save time if they would check to see what cardiologists are in their insurance network. And so we can move things along a little bit faster. And then, so after, we've had the visit, we've gone through the concerns, maybe I ordered some tests. The follow-up is important. Follow-up is very, very important. So I'll talk about sort of reviewing the test results, maybe the ones that I ordered. So I want, in general, for patients to come back to review test results, the good ones and the bad. I want them to know, for instance, if we've been looking at your blood sugar, I want you to know, first of all, what your blood sugar is, and second of all, how it falls in the normal range, so that you don't have to wait for me to say whether that's okay or not. You already know what the numbers should be because we went over that, and now you know exactly where you stand. I want you to know what your hemoglobin A1C is. I want you to know what's considered okay and what's considered outrageous. So if you come in and do that follow-up, we get an opportunity to review those test results so that you just become more educated. Another situation is, and this is very, very important, hospital discharge. So when patients come out of the hospital, they should come in for a follow-up visit. A lot of what we do is to review what happened, because sometimes patients will come in and say, I don't know what happened. I don't know what my test results were. I don't really understand what was done. So that gives me an opportunity to fill in that information for them. Something that happens, unfortunately, quite frequently is the hospitals will have formularies, medications on their formularies. And I think probably the cholesterol medicines is probably the best example that I can think of right now. So I may have a patient on one medication, they go into the hospital, but that's not on the formulary. And gone are those days where patient can bring their medications from home and take them. The hospitals don't generally allow that anymore. So they'll put the patient on a medication that's on their formulary. And when the patient goes home, that medicine is on their discharge list. So the patient will take the medication that they were sent home on, plus the ones that they were taking at home, a different medication. And lo and behold, now you have them taking 2 medications for their cholesterol. And like I said before, that's not a good thing. So, so we get a chance to decide, what medications we want to continue, understanding that they may have been put on a medication just because they were in the hospital. Another really good example of that is diabetes. So for some reason, you could be well controlled on oral medications at home, but if you go in the hospital for any reason, they're going to put you on insulin. And so now the patient comes out thinking that they need to be on insulin, but when they come to the office, we're going to go back to what was working. And so that follow-up is very, very important. To have them continue on a reasonable regimen. The other thing is that sometimes when patients come out of the hospitals, they need to have follow up with specialists. And so that's something else that we can coordinate. Again, make sure that the person that they are scheduled to meet with is in their insurance network and those kind of things. Let's see what else. Oh, and the last thing that I wanted to mention, and I spend a lot of time with my patients on this, and that is that if the patient is going to a specialist, I really try to prep the patients as much as possible about what kind of conversation there may be. I don't like my patients to feel
Your
like
audio went out, Dr.
my
Willard.
audio went out.
Well, I can hear you, but you're more or less in a cave. Something changed with your audio.
Okay, I don't know. Let's see. Okay, can you hear me better now?
Yeah, go ahead, continue.
Okay,
It's fine.
okay. So what I was saying is that if I'm sending a patient to a specialist, I like to make sure that they are prepped as much as possible. So for instance, if the patient is going to an orthopedist for knee pain, because I do primary care, I want to make sure they've already been on an anti-inflammatory if necessary. There's some topical things we may have tried. So I'll do all the primary care. I will do at least an x-ray. And so that when they go to the specialist, they get specialty care. They shouldn't go to the specialist to get primary care. And the specialists really, really hate it when a patient shows up and they haven't had anything. So that's important. If I think the patient may need a surgical procedure, I want to sort of prep them as to what kind of surgery they may need, what the rehab may be, and again, just to give them as much information as possible. Sometimes I have to give people bad news. And when that happens, I prefer to do that myself because, and if you need to cry, scream, do it in front of me, because when you go to the specialist, they don't have time. And so I want them, by the time they get to the specialist, to have, had their moment and then have their questions so that they can get the most out of those visits. So that's basically what I wanted to cover. I think that the primary care physician or the primary care provider has a very important role in continuity of care and helping the patient be prepared, knowing the patient's family, and just really kind of providing a framework for good care. So thank you for your attention, and I'll take any questions if anyone has any.
Anybody have any questions for Dr. Wheeler? Okay. Well, Dr. Wheeler, thank you. We appreciate you. I'm going to go ahead and turn this over to Lucky. She has a few things that she would like to say before we have Dr. Thompson to take us out. So Lucky.
Thanks, Chanel. I just wanted to real quick, well, first, I don't have a question for Dr. Wheeler, but I do want to say thank you very much for that information, for making the distinction between primary care and a specialist, and for also just making it clear that the primary care physician is the one that you can kind of let it all out. And it explains so much about my sort of experience with specialty care and a primary care physician. So that was really, really helpful to me. Secondly, hello, everyone. I think I've met a lot of you here. My name is Lucky Camargo. I'm with the Siani Urban Health Institute, and it's part of the Siani Health System that Dr. Johnson gave a great background on. Thank you so much for that. I just wanted to let you know I'm a community engagement specialist with Siani Urban Health Institute, and we're the research arm of Siani Health Systems. And one of the reasons that we were able to be here today and have your time is largely thanks to Diane Powell, who serves on the Community Advisory Council that we establish at Siani Urban Health Institute. And what makes us kind of distinct to other research organizations is that Community Advisory Council model, which is a culturally responsive way of evaluating programs. One of those programs being the Clinify integration for the Southside Population Health Collaborative that Dr. West presented on today. And as part of that, one of our roles in doing this is disseminating this information, the data that we collect, the analysis that we do, and just kind of letting folks know what's happening at Siani Urban Health Institute. So I want to thank Healthy Living with Vision. I want to thank Chanel. I want to thank Dr. Johnson, everyone here for your time, for opening your doors to us and giving us the opportunity to share this information. Most importantly, thank you, Dr. West, for making time today to present on this really important work, really fascinating work. I'm really excited to hear more about it nationwide. I'm going to be following it very, very closely. So with that, I'm going to hand it back to Chanel.
All right. Thank you, Lucky. We appreciate that. And we look forward to having future collaborations with you as well. So we're grateful for that. Before we go on to Dr. Thompson, I did get someone that raised their hand that said that they had a question for Dr. Wheeler. So you can go ahead and ask your question, LaJewel.
Yes, thank you. This is a great opportunity, and a lot of things are going on. Having worked in the healthcare area for 50 years, I really like Dr. Wheeler. I think she's very, very succinct and to the point. And I think some of these things need to kind of change a little bit in terms of having somebody like her to just explain to patients while they're waiting in the waiting rooms, and to talk about a lot of the things that she talked about today would be most helpful. You know, having spent my last 5 years at Cook County Hospital as regional director for outpatient clinics, this was something that I found that people, it was a lot, because when they were seeing the providers and you're only getting 15 to 20 minutes, they're only not addressing a lot of things. And this is a problem because people don't know. They come with 5 or 6 different complaints, and you can only answer a few of those. So I think the issue is, you know, when we're sitting in when they're sitting and waiting to be seen by a physician, we should be having educational films on where they are basically going through what to expect. You know, when you come, make sure, what is your medicine? What is your A1C? And then have them working as teams. So you have a team. If you got all of these basically patients with diabetes, we should have a diabetes team that includes basically the physician that runs it, the nutritionist and everything else. And I think this is, we're still kind of caught up in all of this thing where people come in and they sit and they wait and they give them medicine and they go back out. So I'm really, Dr. Wheeler, I'm impressed with you. I don't know what hospital. I'm on the board at Friend Health with our FQHC. And, you know, and I see some of those kind of things. And so I mean, I think it's really important. I've kind of gotten out of it, but you know, they draw me back into it. So I think that, you know, we have to think about doing things another way, because if people know better, they'll do better. And I think we have to have that, because if we don't, I mean, I think we're still going around and around and expecting different things to happen. And that's not going to be the way it is. But I really, this is my first time I've been invited to this. Somebody sent me an invitation. I think you guys are doing a wonderful job. You know, but it needs to get out, you know, because I just don't see it. It needs to get out. So those were my comments.
Okay. Well, thank you, LaJewel. I really appreciate that. Really do. And it looks like Diane has her hand up. So go ahead.
Yeah, I just wanted to acknowledge that Jewel Thompson was the president and CEO of Roseland Hospital for many years. And also my sorority sister, I sent you the invitation.
Oh, okay.
And thank you so much for your comment. I think that the needs of the patients, you know, can be handled in various ways. Care teams are, you know, is one way to do it. But I think that you're absolutely correct that we have to keep trying. We have to keep trying to help people understand what their medications are and their conditions and potential side effects and, you know, all those kind of things, all that information. I think that you're absolutely right. And I try to do it on a one-on-one, but certainly, and I give out a lot of handouts too, you know, so that when patients leave, they have some information too. So the time that we actually spend with the patient can be limited.
Yes,
But
it is
certainly,
limited, 15 to 20
yeah,
minutes.
it is.
And I think the reading is another issue, because I'm an educator as well. And a lot of people don't understand and they can't read, you know, or they're misreading. So I
Correct.
think that's where the reason why when they listen to somebody, I think automatically they, you know, if they could see something and they could think about this, oh, wow, I can remember this, you
Right.
know, and
Yeah,
it'll be a
yeah,
lot
yeah.
better. Mhm.
Yes. Thank you so much.
All right, thanks. Nice meeting you.
Right.
Thanks.
Well, thank you. We appreciate all of those comments. And if you have any more, you know, we will definitely try to take some at the end. But we're going to go ahead and we're going to turn this over to Dr. James Thompson, who is a phenomenal allergist in the Chicagoland and South suburbs. Take us away, Dr. Thompson.
All right, thank you. I'm going to see if I can smoothly transition to my slides, but yeah, I've been a practicing allergy and immunology, seeing probably 70%, 60 to 70% of the patients I see have asthma, and many patients that have asthma also have allergies, allergies that involve their nasal passages too. So the kind of mundane term is hay fever, but some people call it sinus allergies. The technical term is allergic rhinitis. So I see people that have that and hives and swelling. And I'm certified in internal medicine as well as the specialty of allergy and immunology, and I have a certification in nutrition coaching, and that's actually going to be more of my focus. So I'm going to see if I can transition to sharing the screen here. My first slide, eating your way to better health. Do you still hear me? Everybody still with me? Okay, I'm assuming it's okay. Okay, good. Eating your way to a better health. I think this is a great way to help yourself prevent some of the most common diseases, including cancers, by eating healthy food. And I'm going to go more into that because the major focus here is looking at the major diseases that take us out. And although COVID has been running the headlines for a long time, only in recent months has it tended to back down to other topics. It's still the third leading cause of death when you go through most of 2020, 2021, and 2022. What's killing more people each year is heart disease and cancer. And I've listed 8 of the top leading causes of death, and 7 out of these 8 are modified by diet and lifestyle. And I'm not talking about a little, I'm talking about 80, 90% modification. And so if we actually make changes in our diet and lifestyle, we can avoid most of the top diseases that take us out. But I'm focusing in on heart because that's the number one. It's the number one killer of men and women. And even you think with cancer, a lot of us hear about relatives and often older people that may have cancer, but a lot of people with cancer that have survived chemo end up dying from heart disease. The most common reason for death for women that have survived breast cancer is heart related. The most common cause of death in cardiologists, if you take cardiology specialists, heart specialists, is heart, ironically. And so the heart does matter. And if we look at this slide here, we see that Blacks are disproportionately impacted by heart disease. Really, more than half Black people have high blood pressure, nearly half of people in general. But you can see there is some disparity here in terms of the percentage of people that have this, with the highest number being African-American females in terms of heart disease. And although Latinx are down there in the lower quadrants, they still have some other problems that they surpass the majority in. For example, diabetes and liver disease. And so if we look at this chart, we see when we just compare whites to Latinx population in the US, we see diabetes is much higher on the list there. And diabetes is a major risk factor for heart disease and cardiovascular disease and strokes. And you see stroke is number 4 for people that are in that demographic. And so there's a lot of work to be done, but these can all be addressed with diet and lifestyle. I'm not saying necessarily cured, but significantly impacted and certainly prevented. Now, this doesn't say at the top of the slide, but this is an analysis of people that have diabetes. The Native Americans have a particular high risk and high prevalence of diabetes. But as we can see too, compared to non-Hispanic whites, Blacks are kind of leading after Native Indians, and then right behind are Hispanic Latino Americans, and whites are at the lowest end for that. Now, of course, it doesn't show on the slide. That was for type 2 diabetes. It's reversed for type 1. It's an 80% percentage, white versus Black at least, for type 1 diabetes. And type 1 diabetes is the type that involves where you lose complete function of your cells that make insulin. It happens at a younger age. And it's more of an autoimmune process versus diet and lifestyle. Type 2 is the most common form of diabetes, which generally occurs later in life and involves kind of a slow process where you lose function of those pancreas. They're called beta islet cells that make insulin. Now, often people will go many decades and still make some insulin, and they don't need often insulin infusion. But if you don't do anything about it, you can get to that point where even with type 2 diabetes, you need insulin injections. This slide just shows the difference in in managing blood pressure, or rather the effect of managing blood pressure in whites versus Latinx. And as you can see, although the incidence of blood pressure is lower, as the slide I showed you before in Latinx, the control of it is less compared to whites. So almost 70% don't have it well controlled, where it's about half for the non-Hispanic whites. Now, if we had the Black column up there, it would not look good either, about 1 in 5. Now, if you look overall across all ethnic groups, only about 1 in 4 people have well controlled blood pressure over a continuum of several years. And that's really bad. there's 1 in 5 that actually don't even know they have it. And so the key take-home message there is that we should make sure that we have our blood pressure checked, really from age 5 above. There are children now, because of the standard American diet, which I'll get to, that are having high blood pressure and diabetes because of diet, because of lack of physical activity compared to previous years, decades, and to a small extent, genetics. So what is high blood pressure? I just want to make that clear, that blood pressure is not normal when the upper number is above 120. And when the lower number, which is called diastolic, the upper number is systolic, the diastolic number, when it's above 80, it's abnormal. So it's elevated when it's a certain range, like 120 to 129. And if it's considered stage 1, the first stage of high blood pressure, if that upper number is above 130, and if that lower number is between 80 and 89. It's considered stage 2 when the upper number is above 140, which is systolic, and the lower number is above 90. Now, when I was in medical school back in the 80s, the 140/90 was the cutoff for treating and labeling somebody as having high blood pressure. So why is high blood pressure a big deal anyway? Well, there's a shearing force, a stress force on the blood vessels when you have high blood pressure, and it can damage the walls of the blood vessel, as well as other things like items that we eat in our diet, fatty foods, things like that, cholesterol. And when there's an injury, there's a repairing process that actually causes the wall to bulge out because of an infiltration of certain subtypes of cholesterol and inflammatory cells. And when that happens, that narrows the lumen, that tunnel, so that there's less blood flow beyond that point. Sometimes it ruptures and can really cause a problem, because that ruptured part can block smaller blood vessels downstream and cause heart attacks or strokes. Now, there are different kinds of strokes, but the most common is the clotting stroke, where something breaks off, as you can see in this slide, from a plaque, and then can create a situation where parts of the brain does not get adequate blood flow. Someone can also have a hemorrhagic stroke if your blood pressure is really high and you're susceptible to it, perhaps by a genetic vulnerability, predisposition, or by having a history of an aneurysm. Then that can rupture and it can bleed. And that's called a hemorrhagic stroke, which can be a devastating thing. Blood pressure also tends to impact your kidneys. Diabetes and hypertension, high blood pressure, greatly impact the kidneys, and Black people tend to have a higher risk of having kidney failure because of often untreated or inadequately treated blood pressure. There are different stages, and I don't have time to detail each one, but note that when you're 90% in terms of the function of your kidney and filtering the blood, you're kind of in the green zone. It starts to get a little shaky when you get down to 60. And when you're at stage 5, where you're less than 15% of being able to clear the waste from your blood, then you're really heading for all-out renal failure and needing dialysis. And it's hard to reverse it when it gets that low. And like blood pressure, kidney disease tends to be silent. You don't know, often you don't feel your blood pressure being high. I've had so many people saying, well, I can tell when my blood pressure is high. And the problem is, maybe they can, but the majority of the time it's a silent killer. So you really can't tell. Sometimes you can tell when when your heart is throbbing a lot more and you can feel the pounding in your head, but that's usually when it's been high for a while. And there are other mechanisms, other things going on that tells you, okay, this is bad. So you don't want to wait for symptoms. That's the bottom line. Heart attacks are when parts of the heart die. Yes, people survive them. They have stents and things like that. But the key is to change your diet and lifestyle so that perhaps you can hit this off before you have a heart attack, before you have a stent, before you have a stroke, before you have kidney disease. And that begins early in age. That should start soon after you're born. If we look at cardiovascular risk factors, these are 9 of them. Notice it doesn't include genetics. There's nothing we can do about our genes. We can't change our parents, right? So we suck it up, and we know we may have a higher degree of salt retention or some other factors that impact us having problems with our heart and vessels. But the thing about it is diet and lifestyle trumps that all. You can overcome your blueprint by what happens and how these genes are expressed by having a healthy diet. These risk factors, unhealthy diet, lots of fats and lots of dairy and things like that, can increase inflammation and increase heart disease. Smoking certainly does. Lack of exercise does. Being under a lot of stress, chronic stress, increases your risk. High blood sugar, that's diabetes when it's at a certain level. Obesity, figure out your body mass index and you can tell if you're obese. Go online, put in your height and weight, the BMI calculator, B as in boy, MI, and you can, if it's over 30, that's in the obese range. It should be below 25. Excessive alcohol drinking contributes to high blood pressure as well as cancer, increasing your risk for cancer, and certainly abnormal cholesterol. And diet can be a big factor. Diet is a big factor in cholesterol. Sodium is a huge component of having high blood pressure, and Blacks tend to retain it more. There have been debates on why that is. Was there some kind of selection in the Middle Passage with slaves, with Africans being brought from Africa and enslaved and brought to America? But it didn't stop there. Working in those plantations too, a lot of people died. The stronger survived, and they tend to be the ones that could retain salt in that dehydrated state. But there's also a genetic basis for that too. Africans have a tendency to retain salt also. So it's not just that selection process, but we need to basically watch our salt and eat very little of it. Processed food has lots of salt in it. And generally we should have 2,000, somewhere between 1,500 to 2,000 milligrams of salt. But the standard American diet has 5,000 to 7,000. So right off the bat, we get into trouble with sodium. And here are just some examples of some of the foods that get us into trouble. And probably some of you, your mouths start watering when you see this. Pizza and soup. Soups are loaded. You look at a can of Campbell's soup, you'll see it's loaded with salt. French fries, they salt the fries before they fry them and after. Cheese is loaded with salt and fat. Deli meats, processed meats in general, your sausage, your ham, your bacon, hot dogs, loaded with salt. But of course, this is America's food, and this is a lot of food that we tend to eat. Chips, people love their chips, but it's total salt, fat, and sugar all wrapped up into a package to give us heart attacks and strokes and increase our risk for cancer, unfortunately. And so a lot of people say, well, I'm cutting back on my salt by not using a salt shaker, and that's fine, but you can see according to this diagram here that that's only 5%. A lot of salt comes from processed food. So when we really get rid of that processed food and processed meat, we can really make a big difference. This food looks good if you've grown up eating a standard American diet, but it can kill you because that's salt, fat, and sugar, the SOS components of poor health. And when you add in the desserts and the candies and sugar, even those colorings, those artificial colorings have been shown now to be detrimental to the health. Coca-Cola, no one should be drinking soda. A bolus of sugar and caramel coloring and all kinds of things like that, just not good for health. And one take-home message I want everyone to have is that we focus a lot on carbs, but it's not all about carbs, folks. It's really about the fat, and the saturated fat in particular increases your cholesterol. It causes more LDL cholesterol, which is damaging to the heart and vessels. And when you eat eggs, you're adding to that cholesterol. It starts with that, and then the insulin resistance occurs, which then can lead down the line to diabetes. So yes, the carbs play a role, and especially processed sugar should be avoided. But when you talk about sugar from plants like fruit and things like that, it's not that sugar that bothers you. It's the fat first. And what happens, the body tends to burn the sugar and store the fat. So major sources of saturated fat is dairy and meat. And so when you're able to relinquish that and replace those with good wholesome calories from plants and from plant-based foods, you do a lot better. Standard American diet is 55% processed food, 30% meat, egg, dairy, only 11% vegetables, fruit, nuts, and beans. And some of these surveys include tomato and French fries, ketchup and French fries as being a fruit and being a vegetable. So really, the standard American diet, also known as a SAD diet, is very sad because it contributes to heart disease. I'm going to since my time is running out here as my timer goes off, I'm gonna just focus on what we should be eating here and a few more points here. You get a low sodium diet when you just eat a lot of fruits and veggies and when you eat unsalted nuts and seeds, if you're not allergic to them, whole grains that haven't been highly processed. When you eat these things, you're automatically getting a low sodium, higher potassium intake. And potassium tends to counteract the effect of sodium and the blood pressure. So natural food like that will really help, the whole less processed food. And replacing unhealthy fats with healthy fats. I don't necessarily agree with a lot of oil, even olive oil, limit that. Certainly not margarine, that's been kicked off the list, so I need to update this slide. But healthier forms of fat are from like avocado, nuts, and seeds, and things like that. I think fish has a baggage too with being so polluted with heavy metals and things like that. You can get an omega-3 from flaxseed and other sources, walnuts. So we don't have to go too high on that. The thing about oil is that it has dense calories. It has more than twice that of sugar. Sugar is, it's just 4 calories per gram. Oil is 9 calories per gram. And so when we consume fried foods or foods with a lot of oil, we get in a whole ton of calories. Whereas if we consume whole foods with the fiber, which is what our gut microbiome loves, we get full faster. And so look what 400 calories to the right is. Look at down to the bottom there, 1,200 calories of fast food, like from some of the restaurant chains we go to, versus more whole food. You can eat, so you get full and you get healthier food with less of the calories. So the key is prevention. It's really about creating a list of healthy foods, whole foods, and going to make sure you have that list so that you can utilize it for your day-to-day on weekends. If you don't work weekends, get it done. Have a red zone list. Don't eat, get the fried food off the table, the sodas out of the cup and the shakes, and the pastries, donuts, cookies. I know that sounds good to a lot of you, but that's what's killing us. The ice cream, they can be veganized. They can be veganized, where you can have substitutes that taste just as good. You allow your taste buds to come down to earth and retrain them. This is a list I had in 2015. I made a list of 15 foods and made sure I had them and made sure I ate them every day. Not all of them, but I started off with at least 2, 3, or 4 servings per day, worked my way up to 9 to 10. So I now eat at least 9 to 12 servings of fruits and vegetables or legumes, which are beans, whole grains, every day. And I'm not missing meat at all, not missing egg or dairy. So my time is up. I'm going to just show that this is the rainbow that you should really consider, the natural rainbow that has antioxidants, and that your gut will love, the bacteria in your gut called the microbiome, that has influence on every aspect of the body, the heart, the hormone balance, you name it, the immune system. You want to go green. You don't want to go with the processed meats and these other foods that kind of take us to the grave faster. So we want to eat right. We want to make sure we get enough rest. It's not all about food. We want to make sure we regularly exercise, socialize. There's some oxytocin and other hormones that get ramped up that help us when we do good with, in a collaborative way. And challenge your mind. Once you get my age, in your 60s, you want to make sure you keep your mind challenged, because it needs to exercise just like the muscles. So the key is to take the first step, realize it's a marathon, not a sprint. I have a website, Fearless MD 21, which I put a lot of information that I've talked about in much more detail. Of course, visit our Healthy Living with a Vision Facebook page and website. We're about doing a lot of programs like this through the course of the year. And there are plenty of other resources to assist you on this journey. So I thank you, and I'll hand the mic back to Chanel. Appreciate your time.
Thank you so much, Dr. Thompson. Really appreciate that. That was really good information. Does anybody have any questions for Dr. Thompson? Okay. Well, if you do have any.
Tony has a question.
Okay, go ahead, Tony.
Hi, good evening, everyone. Hi, Dr. Thompson. As a nurse, and you know that I'm in a nursing organization, when we go out and do our health fairs, resource fairs, and we're doing blood pressures and BMIs. Do you know where we could find a BMI chart that is representative of an African American community? Because the one we have, everybody is obese, and they still have the current a current date on it, but you can tell that it's not. So you know where we could find a BMI that is as they say, DEI now, since that's what we should be doing.
Well, I'll tell you, BMI is a formula that uses your height and weight, and the charts kind of relegate it to target points based on parameters like age and gender and all that. But really, the BMI calculator, it doesn't matter ethnic group or all at all. Where it gets a little off in accuracy are people that are bodybuilders, where you might have a higher BMI. You might say a bodybuilder might have a BMI of 26, 27, and we know if they're a bodybuilder, okay, that's fine because they have more body mass from building their muscles. And in some older people where they have some loss of muscle mass, some people, it may also be inaccurate there. But generally speaking, it's a good rule of thumb. And I would just say use a BMI calculator, which is easy on your smartphone. Just go online, a BMI calculator, put in your height and weight. There's no ethnic variation with that. If you have a BMI that's 30, whether you're African American, Chinese, or whatever, you're in the unhealthy range. And so that's how it is with the BMI.
Okay, thank you.
Okay,
All right.
sure.
Linda, I see you have your hand up. You can go ahead.
Great, thank you, Chanel. Dr. Thompson, I appreciate you so much tonight, as do others in the comments. And I'm going to put myself out there. I was diagnosed with a diet-related illness at a really young age. I was only 27. And I think, because I'm Latina and just very similarly to a lot of Black and brown folks, we always surround ourselves with family, with like our cultural foods, and that brings us together. And it's a lot of what I've learned, at least in my experience after my diagnoses, is unlearning a lot of that behavior, and that, those dishes that you pick up culturally and the chronic stress. I'm really glad that you also mentioned that piece too, because often a lot of our communities in particular bear those burdens. And so my question to you is, just based on your observation clinically and just being in the field with your community, do you see like more cases of, hypertension or just chronic related illnesses, based on just diet, kind of happening more now than perhaps your time in medical school? And if so, or if not, what do you think those factors are?
Yes, thank you for your question. And you're absolutely right about the cultural aspects, because most cultures do have their traditions, their rituals, their way of doing things, their family meals, picnics, all these celebrations where, certain foods through the years or decades have been eaten, might be refried beans, it might be barbecue ribs, and so it's, breaking those habits are difficult, and it often you feel isolated, but it's so important because those are the very things, for the reasons I mentioned with the sodium and the fats, that we end up getting into trouble. And so, yes, there is more processed food out there compared to when I was in medical school in the 80s and in residency in the late 80s. There's a lot more out there. Beverages that are loaded with sodium and sugar, all kinds. I mean, the chip aisles have exploded. The kind of chips you can choose to eat and for the crunchiness and all that, loaded with salt, loaded with fat. And so there's so much more out there, and they advertise to children. So you get hooked early. When you go to the cashier, what do you go through? Not a rainbow of produce, right? A rainbow of gum and candy and all that stuff. So you get hooked on this stuff early. And so, yeah, there's more of it now than ever. And, Dunkin' Donuts, Krispy Kremes, all that stuff, the line of Krispy Kremes is crazy. And that is the epitome of poison, with salt, fat, and sugar rolled up in a nice, tasty, sugary, dough, cake. pizza is cake. So really, yes, we're up against a lot with marketing and with culture, with traditions, but we better make these decisions because medicines are getting more and more expensive. Healthcare is becoming more and more unaffordable. Dr. West kind of hit it, we have to have these programs now because it's becoming less accessible, but we need to hit it at the root cause. So we need to also give information to parents that we need to stop giving our children these Chips Ahoy's and these Kellogg's Frosted Flakes and things like that, because we're starting them out early being hooked on sugar, hooked on fatty foods and things like that.
Okay. All right. Thank you, Dr. Thompson. Does anybody else have any other questions for Dr. Thompson? Okay. I know that Dr. Johnson wanted to say a few things. Tony, you have something else? Go ahead.
I just had a question. If you don't mind, can I go back to Dr. Wheeler?
Go ahead.
Oh, hi, Dr. Wheeler. Where in your practice or your facility, where do you see the use of a navigator or a case manager in helping our clients get through the system and get things, an advocate in a way?
That's a great question. So in our hospital system, the most common place where we use navigators is if there's a diagnosis of cancer. So if a woman goes and has a mammogram and she's diagnosed with breast cancer, there's a navigator who is on hand to help, facilitate the appointments. It's funny you should ask that question. I had a conversation with the navigator about whether she should be the one to give the patient the diagnosis or I should be the one. And I told her I want to do the dirty work myself because I want to take the time to comfort the patient, answer their questions. So again, when they go to the specialist, they're ready. They've already been prepped with the questions. They've already been, prepped with, what to expect from the visit. But I do use the navigators. Once I have given the diagnosis to the patient and kind of, give them a heads up on what they may expect, then I have the navigators help out in terms of making the appointments and things like that. And so there definitely is a role. My medical assistant or my nurse will help with some of that. But, maybe I'm a little territorial. but yeah, that's a very important resource. Unfortunately, we don't have navigators for all medical conditions, but for mostly, I would say for cancers is the best use that we have right now.
Okay. All right, Dr. Johnson.
I have one more question, Chanel. I'm sorry.
Okay, go
It's
ahead.
Tony. I'm sorry. Linda Martinez, you're at Sinai?
I am, yes.
And I don't know if Dr. West is still on the call. However, I've been a nurse for 40 years and my clinical background started, and it still is, labor and delivery. So I have a big interest in maternal health, specifically now that the camera and the light is on the maternal health of Black and women of color. And I saw in Dr. West's presentation about the awards that they've gotten at Mount Sinai regarding their outcomes. So I'm curious to see, is there a plan? What is the plan or what is in place to maintain that and improve it, considering where Mount Sinai is considered on the west side of Chicago? They do have some high risk of infant mortality and morbidity. And is there any plan to include doulas and increase your midwife participation? No offense, Dr. Wheeler or Dr. Thompson, but
None taken.
okay. I'm
None
just
taken.
looking at the best outcome because they're supportive, so that was my question, Ms. Martinez and Dr. West, if he's still available.
I have to say, Tony, that is a really great question. And I wish I had an answer to that because I do see the, at least just from my observation and being in several meetings. And we did have a really great colleague who was a doula once herself before transitioning into Suhi, and would just talk about the critical need of having these services available, not to just, those that can afford these services, but more so to the communities that are bearing a lot of the burdens of infant mortality. And we constantly hear about Black women usually being on the receiving end of a lot of that. And so I just want to elevate that those are, I feel like, ongoing discussions. And I really wish I had a better answer. Perhaps Dr. West knows a lot more in his clinical practice and can answer that piece.
I can answer from, again, not being necessarily a clinician, but I've done quite a bit of work in maternal and child health, particularly leading a couple of statewide initiatives, and then both in 2021 and 2020 presented at the Public Health Conference data. And what's been stunning about the data related to maternal health, particularly in Black women, is that over the past 5 years, the percentage of Black women under the age of 30 who die after the first year of birth has grown exponentially, right? And that is in part due to a number of physiological, environmental, and other factors. And that, seeing that, and as I kind of presented at the public health at APHA, I said, if the baby dies, that's infant mortality, and God willing, the mother can endure and then have another baby. But if the mother dies, then you can't have another baby if the woman dies. So there's been a number of initiatives and presentations to the state, HFS in particular, to try to train more doulas and to really focus on maternal mortality. And a number of the initiatives for transformation were not funded in that regard. And so there's still a push in the state to have more of a family systems approach. As I mentioned earlier, that there are FQHCs who are now, including fathers and grandfathers and grandmothers, and really looking at, family systems. And so to answer your question is that, yes, the need is great. We saw across the country during the COVID season, as I heard someone mention it, the number of Black hospitals that closed, but also the number of all of the urban birthing centers that closed, right? So they closed all the old urban birthing centers, and they closed the Black hospitals and went out, getting political, but then that money was shifted to Planned Parenthood, and there was a push on abortions. And so that was real, that was happening in the Black community and in young women as young as 14, right? So you close the preventive care side and you push this messaging to emphasize abortions and C-sections. So, we have to combat like the diet, the messaging that goes into our communities, what people see, what's become normalized in terms of health and behaviors and access. And that's going to take a lot more conversations than tonight, but those conversations are happening, and there are people who are really being brave enough, I can say, that to try to bring those truths to light.
Okay. All right, Tony, you got your questions out? Awesome. Awesome. Okay. Dr. Johnson?
All right, thank you all very much. I'm going to try to summarize, but eye care is a primary healthcare profession, And so I can't help but give a little bit. I'm not going to go through my full presentation, but I do want to point out some high points in terms of eye care and how we integrate with as a primary health care profession. We are running over. My goal was to be done by 8 o'clock the latest. It's a little after 8, but I recognize how everyone is so passionate about this area. So as I said, this is the first in a series of joint presentations that we are going to do in conjunction with Mount Sinai. So I hope people are just happy and looking forward to part 2, 3, 4, 5 if necessary. But we know that racism is a public health crisis. And as I tell some of my patients, just by being Black or brown, that's stressful in itself. And part of the issue is that it's been scientifically proven that Black people do better with Black doctors. However, we only make up 5 to 6% of doctors in the USA that are African American, and less than 2% of practicing optometrists are African American. And so how does eye care fit in? Well, a lot of times in our community, I tell people that we think of as eye care is who has the best buy one, get one free sale on for glasses. And now people looking at, in terms of ordering stuff online, I just want to see, and I want to be able to do it at the lowest possible price. But don't think about the eye care component with that. And so there are various ways in which you can get eye care. However, it is my contention that in terms of the South Side of Chicago, we talk about food deserts. I think it's a primary eye care desert. There's a school of optometry in Chicago. There's one just outside in the suburbs, but there's FQHCs, which Dr. West eloquently talked about what they do. And again, a couple other statistics, 1 in 7 of these people in FQHCs have diabetes. And 1 in 3 of these patients have severe diabetes. So FQHCs are very strongly needed. And then in terms of eye care, there's, I think on the South Side of Chicago, only 3 African-American independent private practices. My practice is just outside the city. So that's what we deal with, more than just glasses and contacts, but look at the person overall. Another area of eye care that's really overlooked, a lot of times we tell people, well, your glasses can't help you anymore because you've lost so much of your sight or other reasons. There's nothing more that you can do. Well, there is a lot more that we can do, but we don't refer enough of our people to low vision specialists. So there's a lot of technology in your iPhone. If you can't make out letters, you can point your iPhone at something, it'll say couch over here, window over here, and a lot of other low-tech aids that we can help people be more independent with vision impairment. And during the pandemic, offices like mine were very instrumental in keeping people out of the emergency room. So in terms of eye problems, eye issues, red eye, conjunctivitis, the foreign bodies in the eye, we try to keep people out of the emergency room because we have the equipment to evaluate those things. We talked about obesity and hypertension, autoimmune disease, with this being Lupus Awareness Month. A lot of the initial signs are things like dry eye pain and inflammation. Glaucoma, one of the leading causes of blindness in our community, is often found very late, where people may develop a blind spot in their field of vision, very small, that they don't notice until it becomes like this and they have tunnel vision. Again, there are no early symptoms, and all the vision loss is permanent. It's not reversible. That's where prevention is really important. Dry eye, real common, but it's related to a lot of times medication, diabetes, normal aging change, environment. But again, it's ignored a lot. People just tolerate it. Cataracts cause very visual symptoms of blurred vision. However, it's one of those things that's easily treated. Cataract surgery is one of the most common surgical procedures done in the country. It's done on an outpatient basis, but yet a lot of our seniors are afraid of it because they hear the surgery word. So we spend a lot of time educating patients and getting them to somebody that's quality. But there are other things like medications and diabetes that can cause the more rapid formation of cataracts. Diabetes is huge. Again, diabetes is the leading cause of adult blindness in this country. 1 out of 3 people have pre-diabetes, and that's one of our focuses. Even with pre-diabetes, we know about your increased risk for developing type 2 diabetes when you're pre-diabetic, but what we don't talk about enough is that you're also increased risk for stroke and heart disease with pre-diabetes. So that's another focus that our healthcare providers are putting us onto. We talk about social determinants of health. This is something that's coming in the pipeline that will be required for most of us practitioners to report. We talk about social determinants of health, and that's what Dr. West is doing, putting that data together, his organization, to see what are the best practices for taking care of people in our population. So problems related to health and literacy. In terms of eye care, there are many people just can't see. For whatever reason, they can't afford glasses or they can't see. That limits their educational opportunity. Our children having issues, being more and more nearsighted, and that relates to your literacy. We know we want Black boys to be able to read by 3 years old, 3rd grade, I'm sorry. Problems related to unemployment. People a lot of times are between insurance plans and put off not only eye care, but health care, housing, economic situations. So these are factors that are more that we're starting to look at and have to document in some of our how we do things. And a lot of these things are related to eye care and how people function and move through life. So that's just really kind of a tease here in terms of how eye care integrates with that. But this is my last slide, and I always say, be well, see well, be blessed. And with that said, I want to give all of our presenters a big thank you. And I want to give everybody like a minute. All of our presenters, I've already spoken, but Dr. West, Dr. Wheeler, Dr. Thompson, if you can give a 1-minute summation and on what you want us to leave with. And this will be on our website, so people will be able to reference it. And we can move forward with further town halls. This has been exciting, folks. So Dr. West.
I can, well, I guess I can go. I just want to thank everybody for the opportunity. Appreciate, being allowed to join the panel, and just if you have any questions or anything for me, please just let me know.
Dr. Wheeler?
I just want to say that I just think that this was a wonderful forum. Some really good information was disseminated here. And just from my standpoint, just be reminded of the importance of the primary care physician as somebody that can help coordinate care and help educate patients. I think that even as we get more and more technology and things, that primary care person is still going to be relevant and needed, and should be an integral part of the healthcare team. So thank you for your attention.
Thanks, Dr. Will. Dr. Thompson?
Yes, I want to thank all my co-panelists and thank you, Chanel, for doing a great job, and our hosts and our partners in this effort with Mount Sinai. This has been a wonderful experience, and just say that this is just the beginning, as Dr. Johnson was saying. I think we often want to make sure that we put our oxygen mask on ourselves first. So that's kind of a metaphor for making sure that we do healthy things so that we can live longer, and not just live more years, but live quality years where we're not hooked up to machines and medications and things like that. And one of the best ways of doing that is through a holistic approach with diet and lifestyle. So Good luck with everybody. Be blessed.
Well, again, we want to thank you guys for this evening. Lucky, thank you for the collaboration. Thank you for Diane. We appreciate you. Linda, phenomenal. We are gracious that we were able to make this collaboration, and we look forward to future collaborations with the Siani Group. Again, make sure that you visit our website. It's healthylivingwithavision.org. We have donation links there because without donations, we can't manage, but we do the best we can because it's coming from our heart. So everyone have a wonderful Friday and make this weekend the best ever. Take care.